So, the moment that we all look forward to is when the ulcer is closed. So, there will be no drainage, there's no need for another dressing, no visible defect, and the patient smiles and says, "Yes, doc, it's finally healed." And everybody breathes a sigh of relief. But clinically, there's still a huge risk because in diabetic foot disease, healing is not the endpoint, healing is the transition point. I usually tell my patients you're in the remodeling phase right now, and it lasts more than a year. That's the phase that you're in wound healing. And what follows is not recovery. We also have to follow maintenance. Okay, maintenance medicine. Because most amputations that happen after healing doesn't happen because the wounds fail to close. It usually happens because the patient forgets that there's still a high risk foot, right? But like previous physicians have said in the past, what I've noticed as well, patients who've had an ulcer and healed, they are very, very on top of it. Like, even if it's a small little cut or anything like that, they're on top of it. They make sure follow up because they went through such a hard time with the first ulcer, okay? So we're gonna break down exactly what it does mean to be healed, right? So for that, and welcome back to Diabetic Foot Files. So, for thousands of years, physicians believed that wound healing ended when the skin was closed, right? And ancient Egyptians documented wound closure as early as 1600 BCE. That's pretty cool, right? And ancient Greek physicians such as Hippocrates recognized that wounds underwent stages, but did not understand it to the cellular level, unfortunately. They didn't have microscopes then. And it wasn't until the 1800s that scientists began using microscopes to observe the collagen formation, the scar formation, and the tissue remodeling. And by the mid 1900s, so this is recent, researchers discovered that wound healing actually occurs in four overlapping phases, which is hemostasis, inflammation, proliferation, and our favorite, remodeling. I mean, I love the proliferative phase. And I mean, we should love all the phases, but I love the proliferative phase because it's like magic for me. And major breakthrough came when scientists realized that the remodeling phase can continue for months to years after the wound closure, meaning that the wound can look healed, but is still biologically quite vulnerable. So let's define healing properly. So in diabetic foot pathology, a healed ulcer means the surface is closed, full, complete re-epithelialization. That's what I say or type on my charts, right? No drainage, no open tissue, okay? No probing, no tunneling, no undermining, nothing, okay? But underneath the structural reality of this area where the diabetic ulcer healed, the collagen is pretty disorganized and quite weaker. The scar tissue has reduced elasticity. The microcirculation is still a little compromised. Neuropathy is unchanged, right? And pressure mapping on the foot is still abnormal, okay? Because you have to remember these patients, their feet structural anatomy, the structure of the foot does change with time, especially with diabetes and diabetic neuropathy, okay? Because always think like insurance minus foot doesn't affect everybody, but it does happen quite often, right? But what do we actually have? We have a biologically altered foot that is temporarily closed, okay? Like I said, I always tell my patients that you're in the remodeling phase. It can last for a while, it's almost a year. I always say over a year, but it can definitely last more than a few years. So I'm like, you're at this stage where you have to baby it, quite vulnerable. You're gonna have to baby this wound, you know? And you have to remember a lot of our patients have neuropathy. So they can feel when there's a lot of big shear forces or pressure along that area. So definitely, we know that one of the people that they definitely need to have intervention from is the orthotist and the insole, right? But we'll get more into that. But so it's biologically altered and temporarily closed, right? And that does not mean that the wound is fully restored. That does not mean that the wound is fully normal. I even tell my patients it will never get to the full skin integrity ever again, unfortunately. So it still is more fragile than the other areas of your skin that never had a wound there. Okay. Does not mean low risk. And, recurrence is quite common. And the problem really that recurrence is quite common is because patients have pressure because everybody's on their feet, right? Pressure, neuropathy, vascular compromise, and repetitive trauma, okay? And none of these disappear when the skin is closing. So, what is true wound healing? A wound is not considered biologically mature simply because it's covered, right? Clinically, the wound may be closed, right? But pathophysiology-wise, the tissue is still undergoing this remodeling phase. So they're having the collagen reorganization, the scar maturation, the vascular regression, the cellular apoptosis, and mechanical strengthening. The scar is consistently being rebuilt over a long period of time while epithelialization occurs. So the remodeling phase is the longest phase of wound healing, right? I mean, a lot of our patients are stuck in that inflammatory phase of diabetic with the diabetic foot ulcer could was it give run for money for being the longest phase of healing when it comes to that. But usually it is the remodeling phase. The remodeling phase begins approximately like supposed to, okay? Like 2 to 3 weeks after injury. People are usually supposed to be healed within like about a month, right? But we have our patients who have chronic wounds and there's something that is a barrier that's blocking the healing, right? But remodeling phase can continue for about 6 months to 2 years, and sometimes even longer for our diabetic patients. Okay, so that's why recurrence is so prevalent as well because they're still in the remodeling phase. Okay, this phase is quite essential to the construction project or where the body replaces the temporary repair with a stronger repair. So, what's happening microscopically? Collagen replacement. That's a lot that's happening during the remodeling phase. So, early wounds are primarily filled with type 3 collagen. And type 3 collagen is quite weak, quite disorganized, and quickly produced. Think of it as emergency scaffolding, and the body gradually replaces it with yay type 1, right? That's what we want. Type 1 collagen, which is stronger, more organized, more resistant to stress, and the ratio gradually shifts towards being predominantly type 1 collagen. Now, next is the collagen cross linking. So, collagen fibers begin forming this chemical cross links, and these cross links help increase the tensile strength, improve durability, and allow force distribution. And without the cross linking, the tissue tears quite easily. And this is why a freshly healed wound frequently reopen. Next is our fiber alignment. Okay. So collagen fibers initially resemble a tangle bowl of spaghetti. But during the remodeling phase, the fibroblasts pull the fibers into alignment. The mechanical stress influences the orientation actually of the wound, and the tension lines develop, and the scar becomes stronger but never identical to the normal skin. That's something you have to like make patients fully understand. And then the vascular regression. So as the wound heals, right? Healing a wound, initially they have a lot of blood vessels because it's an open wound, right? And the body's trying to send all the supplies that it can to close this wound, right? But as the remodeling progresses, access like excessive capillaries disappear, oxygen demand decreases, right? And then the scar tissue becomes quite paler. So this explains why the scar can start like off as red, like then transition to pink and then pale. But we don't like pale. Like I'm like I know when people think pale skin, you think lack of blood flow, but also that's a remodeling is trying to close up, okay? But why doesn't the scar tissue become like normal skin? So the body prioritizes speed over perfection. So scar tissue contains fewer sweat glands, fewer hair follicles, less elastin, altered collagen architecture. And the result is a scar may look normal, but function differently pretty much forever. So, how strong is healed skin? This is a very important concept when it comes to wound care. So, immediately after the closure, I tell the patient the truth. Your tensile strength, the skin strength, is pretty much 10 to 5% of the normal skin strength, your normal skin strength, your normal. So, the wound appears healed, but extremely fragile. It's a baby wound. 3 weeks of the healing, being fully healed in that remodeling phase, the strength reaches roughly 20% of the normal tissue strength. 6 weeks, it reaches about 40 to 50%. And then 3 months, it can reach approximately 60 to 70% of the normal tissue strength. And within a year, it reaches about 70 to 80% of the original skin strength. But I do believe this varies, especially for our diabetic patients. So just keep that in mind, okay? But research constantly demonstrates that healed skin generally reaches a maximum of 70 to 80% of its original tensile strength. The scar remains permanently weaker, okay? And this explains why diabetic foot ulcers do have that recurrence that is quite common. And another thing that's quite misunderstood in moments of wound recovery is that the skin starts to peel. I have patients because you have this wound dressing, let's say for months, right? And we're scrubbing as much as we can, but you're going to have a lot of dead skin because skin cell turnover, right? So the peeling, the flaking, and the shedding after wound has already closed. Patients often think that something is going wrong. I was trying to explain to my patient, don't worry, see, like it's just dead skin, okay? And look, touch it. Like there's normal skin right there. Feel it, and especially in our diabetic foot care patients, because they have such prolonged dressings, right? They have dressing for months, right? For long periods of time, and moisture exposure is involved. So, why does the skin peel after wound? So, after wound closure, the new epithelium is still immature. It's not the same as pre injury skin, like we mentioned. And you're going to start seeing a combination of post inflammatory skin cell turnover, dressing related changes, and barrier reconditioning. So, there's something called accelerated desquamation, and that's post-healing shedding. And one of my patients going through that right now, and I was trying to make her understand it's okay, it's normal. You're peeling a little bit, and look how nice and healthy the skin is. It's like a different color. It's nice and pink now. I told him it's gonna get its pigment back. I promise you, but feel it, like it's actually close. But desquamation is the natural shedding of the outermost layer of the stratum corneum, right? And so after injury, the keratinocytes behave like in repair mode, meaning that there's rapid proliferation during healing, there's disorganized maturation initially, there's delayed barrier normalization. And once closure occurs, the body clears it out. So the body's trying to clear the dead keratinocytes, the excessive keratin buildup, and the residual inflammatory debris, and this creates visible peeling and flaking. Now, another thing that happens is sometimes patients have this dressing-induced maceration. So, if the wound was covered with occlusive dressing or semi-occlusive dressing like hydrocolloids or foams or films, the skin around it is often exposed to prolonged moisture, and this leads to the stratum corneum being overhydrated. There's a breakdown of the lipid bonds. There is a softening and fragility to the epidermis, and this white, soggy skin appearance, which is aka maceration. And when the dressing is removed and the moisture levels normalize, the overhydrated levels begin to dry out and shed. And so the peeling you see is often previously overhydrated epidermis as well, okay? Returning back to its normal barrier state. Next is our barrier remodeling, right? So, newly healed skin does not immediately regain its full protective lipid layer. Okay, so normally skin barrier consists of the keratinocytes, which are like our brick structures, and then it has lipids, which is our mortar structure. And after healing, the lipid production on our skin is incomplete, and the corneocytes alignment is quite immature, and then the water loss is higher. So there is an increase in transepidermal water loss. And so the skin reorganizes itself, which is often present as it peels or scales, okay, during after healing, okay? And then drying out after occlusion, like I was mentioning, this high moisture environment that some wound dressings do create when now that you're healed, you are exposed to open air, there's a rapid evaporation, the skin tightens, the superficial layer of that skin detaches, especially it's noticeable on the plantar foot because there's thick corneum. Skin responds dramatically to the environmental change. Because I can definitely say when we're cleaning a wound, there's gonna be a lot of dead skin, especially when the wound heals. And then, I always baby the surrounding skin as the wound dramatically gets smaller and smaller. Definitely baby it, but there is a lot of skin cell turnover. So normal skin cell turnover, and this is for a non-diabetic patient, epidermis fully renews approximately about 28 days. That's the baseline cycle for complete keratinocyte turnover from basal layer to desquamation. But after healing, after wound healing, right? After injury and reepithelialization, turnover is temporarily altered. So early remodeling phase is about 2 to 4 weeks of instability. Barrier normalization, 4 to 8 weeks. Full functional maturation, about 8 to 12 weeks. But for me, what I've learned is it really does vary per patient and then how much pressure they put on it. Okay. So even though the wound looks closed biologically, the skin is still reorganizing itself. Okay. Up 3 months to even 2 years, I believe. Okay. So in diabetes in our patients with chronic wounds, the turnover is much slower and less organized due to the hyperglycemia. That's why it's so good to have your blood sugars normalized, your hypoglycemia normalized, right? Hyperglycemia impairs the keratinocyte migration. There is reduced collagen quality and the microvascular insufficiency, as well as the chronic low grade inflammation that happens during diabetes. And this can extend our functional normalization of the skin cell turnover to from 6 to 12 weeks to even longer. Okay. So is peeling normal after healing? Absolutely. Yes. Okay. Normal post-healing peeling usually looks like fine flakes of scaling. That's what I'm going through with one patient. A lot of dry skin, superficial skin. There, and you know what? I do understand them not picking it. I'm very proud if they don't pick it. I'm like, yeah, you don't have to worry about picking. But they have to get to a point of confidence that you can take care of this area yourself now that you're healed. So you can wash it, and we'll go through that too. Okay, because I do realize a lot of my patients are hesitant after they fully heal to wash the area. And we're not asking you to wash it like normally and rough and hard or anything like that, right? And they know the signs to look out for if anything opens. And I had one patient, she was just scared to see like any blood, right? She was scared. I said, honestly, to be honest, it's not that I told her it's not that scary if there's a little bit of blood, okay? If there's a little scratch or whatever it's just a little bit. I told her to just contact me, and I told her what exactly to do, but I just explained to her how fragile the skin is, but they are very hesitant because of the long journey, the long tedious journey that a lot of them have been through with wound healing, and to get to this point, they're afraid to undo what was done, right? Undo all this healing and hard work. This is a lot of hard work for them. So, when does peeling become a problem? Peeling is concerning if it's associated with this redness spreading around the area, if there's a foul odor or drainage, if there's pain or burning, especially in a neuropathy reversal case, if there's cracking that opens the skin up again, or if there are any signs of infection or recurrent ulceration. So, in a diabetic foot, the key concern is, does this peeling progress towards breakdown? Okay, is it breaking down the area? Then that's a concern. And this matters to us in diabetic wound care because the phase where recurrence often begins, not because the wound reopened, because the skin barrier is still immature. The skin is mechanically weak. The moisture balance is unstable. It's trying to normalize itself, and the pressure is still present. So peeling of the skin can become an entry point for fissuring, callus formation, and re-ulceration. But bottom line is, skin peeling after wound healing is usually a normal remodeling and barrier reset phenomenon driven by post-inflammatory desquamation, moisture-related maceration changes, and epidermal barrier reconstruction. The skin is not fully stable until roughly I'm gonna just have to say 6 months, and that's in my opinion. That's me just giving a rough estimate, okay? Yes, it's closed, it hasn't opened back up after 4 weeks or whatever, but I let them understand we're in a high-risk transition period. This is not true recovery. This is a remodeling phase. This is the phase they're trying to make the scaffolding stronger, okay? Because the skin looks healed before it mechanically is ready. So what is the correct way to wash the diabetic foot once it's healed, right? This is where some patients make two mistakes. Some patients over clean, right? And you're damaging the skin barrier because remember I talked a little bit about the lipid bilayer, or patients under cleaning. So if you're under cleaning, you're allowing breakdown, you're allowing like fungus and skin debris to accumulate. So, when it comes to washing, I would use some people say lukewarm, I would just say room temperature. When it comes to cleansers, pH balanced, a mild fragrance-free one. Some doctor it depends on the patient and their lifestyle and what is they're prone to, right? So, if some of my patients are very prone to having tinnipedes or fungal infections or bacteria, I do recommend a nice antifungal wash. Sometimes you can actually make your own for the patient with a compound pharmacy, actually, okay? A really good one, a nice soft, mild one that they can wash their feet or that area every day. That's a good option, right? But yes, you can use your hand, a nice soft cloth. We're not using exfoliators, okay? Nice gentle circular motion and make sure we keep the interdigital areas in between your toes nice and clean and dry, okay? Pat everywhere dry. Make sure it's dry, okay? That's the biggest thing. No scrubbing, no exfoliating tools. I do not want to see a pumice stone after on the area where we just fully healed, okay? And like I said, always remember in between the toes is a big fungal risk area. So yeah, and another thing I always tell my patients to avoid soaking. No soaking, okay? Epsom salt soaking, absolutely not. Hot water soaking, absolutely not. I know they love to. I know everybody would love to soak their foot after being months or even a year with their foot dress, right? I get it. No. So, alcohol-based washes, no. Strong antiseptic soaps, long term, I'm a little different. Everybody's different, but no scrubbing brushes, no pumice stones on the healed ulcer site. Mm-mm. Okay? That's like you scrubbing the little baby skin. It's the baby skin. Okay? So if the skin feels tight, squeaky, or stripped, you're pretty much damaging that lipid layer. Remember, we talked about that lipid layer. It actually is a first defense barrier for our skin. So keep that in mind, okay? And then we did a little bit about moisturization. You do have a diabetic foot lotion. Your doctor will recommend the right one for you. But like we said in a past episode, usually they have urea or glycerin, ceramides, and some petroleum in them. But it depends on the patient. Everybody knows their patient's skin type pretty much after wound healing because wound care is so tedious and meticulous. We know our patient's skin after that. Like, I know what can break down my patient's skin because we're figuring it out together because some patients have allergies, some patients don't. Some patients have skin that sweats more than the others, you know? So you learn your patient's skin, okay? But you just have to keep in mind the structural vulnerability of the patient's skin while they're healing, okay? Now, big thing, right? So after diabetic foot ulcers heal, let's talk about some of the statistics when it comes to recurrence. So there is about a 40% of recurrence of diabetic foot ulcers in about a year, a 60% recurrence in about 3 years, and a 65% recurrence within 5 years. And many experts describe that diabetic foot ulcers are in remission. They call it remission, right? Then cured. And once the foot has been ulcerated, it is a permanent high risk area. And so daily inspections are quite mandatory. So, what is the strongest evidence that supports pressure reduction prevents recurrence. It's pressure reduction. I said that too backwards. But offloading remains one of the single most important interventions. Why? Because recurrence occurs primarily due to repetitive mechanical stress. The tissue is repeatedly loaded beyond its tolerance threshold and it eventually breaks down. So what we all need our patients do those daily checks. Check for redness, check the temperature. Remember, there's like smart insoles, smart soles, Sacramento. You could check the temperature of your foot. The back, that's awesome too. So swelling, check for swelling, callus formation, blistering, color changes like dark, dusky, shiny, any areas of new discomfort, okay? And the important truth is pain is not a reliable indicator in our patients that have neuropathy. But like I said, when the pain starts happening and you have an ulcer or wound and it look something is wrong, you need to most likely be admitted. We have to open this up. It really concerns me when you know what? From my experience, it's never been anything that was easy. When they start having pain and they have neuropathy, yeah, it's usually a big red flag. It's usually I've never seen it not be a big red flag, okay? So, even though we still have to rely on our sight, we have to rely on our touch comparison, our knowledge and expertise, and symmetry. Symmet- Symmetry. I don't know why I'm saying that wrong, but forgive me. So, when it comes to surveillance of this wound, right? What are the typical follow-up periods? I have my own follow-up intervals, right? So everybody's different, okay? So everybody's different how they like their patients to follow up, who they follow up with. I let that leave it to the provider because every provider is very different, right? Now, when it comes to footwear, right? Amazing footwear. We always say wide toe box, cushion insole. Some people need custom organized orthotics, right? Seam free inferior, right? In there over the previous ulcer site, shock absorption and stable heel counter. And no barefoot walking, no flip flops. No flip flops, okay? I know it's summertime. I know it's hot, but no flip flops. No tight dress shoes, no hard leather soles, no worn out shoes, okay? And the clinical reality is, there are the shoes are not for fashion after healing, okay? Shoes are for pressure redistribution. And you need to know also when to turn over your shoes and your insole. So always keep that in mind. Now, when it comes to recurrence, recurrence isn't just a sudden overnight event. The predictable pathway of recurrence for these ulcers are increased pressure, skin thickening, so aka that callus formation, microvascular compression, tissue breakdown, blister formation, ulcer reopening, and infection entry. And the common triggers for this usually are new footwear, increased walking activity. I do see that a lot with my patients. I'll be like, "Oh, were you on a trip recently?" Yes. Ignoring calluses, and this is travel season. Okay, I think every part of the year is travel season, but it's summer is travel season for a lot of our patients. Skipping moisturizing, heat, dryness, and minor unnoticed trauma. So most recurrence is through mechanical more than infection first, okay? Infection usually is the final stage, not usually the beginning phase, okay? But the 30-day to 90-day area after post healing is usually a high risk area because a lot of patients do feel like they're healed, but you're in this huge long period of remodeling, okay? Now, when it comes to following up, your doctors know exactly who you need to follow up with, right? But make sure you always follow up. And if you have a question, just ask, okay? Nothing's wrong with that. But also, you have to think about the referrals that you need to do as well. I mean, I would hope that the patient is doing physical therapy during this time, but physical therapy, they need to learn to strengthen their walking better because we do ask the patient to stay off of it as much as possible, unless they're like, let's say, sometimes they're in the exercise program, right, to help with their claudication and things like that. But physical therapy is very important for our gait and pressure redistribution. These people are amazing. They are really great with that. And on top of that, they see and be able to evaluate, sometimes even better than other people, to evaluate their gait and see exactly where they need pressure redistribution, offloading, and oh, is your hips misaligned, things like that. Now, your orthotist, big deal, okay? Offloading is the number one recurrence prevention strategy, okay? So some people need a rocker bottom modification. Some people need custom insoles. Some people need shoe depth adjustments, okay? Because sometimes if you have that big hammer toe, you're going to need that shoe depth adjustment and pressure offloading devices, okay? Next is you already know vascular should always be like vascular, okay? Vascular, okay? They will tell you when to follow up, okay? But you have to remember they play a key role in keeping you and your limb together, keeping that wound from opening up again. They play a very key role. Your endocrinologist, okay? Remember that they are the gatekeepers of your sugar, right? They help with your diabetes management, okay? Because remember, your blood sugar affects the collagen strength, the nerve damage progression, and infection risk. So your hemoglobin A1C optimization is a big key factor in this. Medication adjustment if they need to, and insulin resistant management. Sometimes you might need a dermatological specialist. So that depends on sometimes our patients have other skin conditions, okay, other than ulcer as well. So those are things to keep in mind. Diabetic educator, because the more they know, the more they feel more empowered. And then lab monitoring, okay? but you will know exactly when to follow up. The doctor will tell you, but keep in mind, look for the red flags. You know you're supposed to check your feet in that area every day. Check for redness, skin thickening, new callus formation, warm spots, any blistering, or any drainage that occur. So the biggest mistake in diabetic wound care is believing that the wound is cured when it closes. A closed wound is not the finish line. You're in that remodeling phase. So the remodeling phase may continue for months or to years. The scar never regains the full strength. Neuropathy, pressure, deformity, vascular disease, and diabetes still remain present. And from a limb salvage perspective, a healed diabetic ulcer is the best view as footing remission, they call it remission, requiring lifelong surveillance, pressure management, skincare, and risk reduction. So the wound may be closed, but the biology that created it is still needs to be managed on a daily basis. And in diabetic foot care, healing is not when the skin closes. Healing is when the patient maintains the habits that prevent it from reopening, because a closed ulcer is not the end of the disease. It's the beginning of a new responsibility that we have to give to our patients, and the patient understands that difference, okay? So this is Diabetic Foot Files. I know this one was a little long, but this is Dr. G, and take care of your feet because they take care of you. And congratulations to all my patients that every patient that is in that beautiful remodeling phase, remission phase. We're here for you. We're cheering you on, and you can do it.